here for a very interesting lecture by none other than Dr. Gita Arjun. It's on Cesarean section. Whenever we talk about high incidence of Cesarean section rates, we generally have two questions in the mind, two debates. One which a lot of people ask is whether we should be bothered, and there are a lot of skeptics who say high Cesarean sections rate, so what? So that's one aspect of it. And the other one is saying that yes, high Cesarean sections are there, it's a cause of concern, and we should be trying to address it. So trying to address it is what we're going to try to do. Dr. Gita Arjun is trying to sort it out over the next half an hour. May I ask Dr. Gita to be here on the dais, please? She's a graduate of Madras Medical College, recipient of the G.V. James Prize in Surgery and the Bharati Lakshmi Gold Medal in Obstetrics and Gynecology. She did her residency training in obstetrics and gynecology at St. Francis Hospital, Evanston, USA from 1976 to 1980. She's a diplomate, American Board of Obstetrics and Gynecology, and fellow of the American College of Obstetricians and Gynecologists. She retired in 2013 after 32 years as the director and obstetrician gynecologist at EVK Kalyani Medical Center, Chennai, India, which celebrated its 66th year in 2015 as an institution dedicated to women's health. Soon after completing her training in OBGYN, Dr. Gita Arjun and her husband, Dr. Arjun Rajagopalan, chose to return to India, and they could share the knowledge they had access to during their studies in the USA. She has been an organizing secretary of the very successful Progress series of conferences since 1993, with the conferences which attract 850 to 1,000 delegates all over the country. She's been invited to deliver lectures and orations all over the country, both for the medical fraternity as well as the lay public. She's got more for her CV, but I think we'll leave that, and we'd like to hear from you, Dr. Gita Arjun. Thank you, Dr. Gita.
Way too much introduction. I think if you just say she's also a person who's wanted to practice obstetrics ethically, that's more than enough. I think everybody will understand that I am a proponent of the vaginal birth. Everybody must remember that it's called the birth canal, not the coital canal, right? So please remember, it's the birth canal, and the youngsters here have to be reintroduced to the notion that women can actually deliver vaginally. Okay? Thank you, Sashi. Thank you, all of you, for having me here. And I'm going to talk about decreasing cesarean rates in small individual units. Before I start, how many of you practice in hospitals which are between 5 to 50 beds? So I would say the majority. Okay, right. So that's the kind of place I practice. I practiced 32 years in a hospital with 30 beds. It was not an excuse to do any kind of different kind of medicine. We practiced as if we were practicing in the best unit anywhere in the world, because it's not the money that you spend, but the kind of care that you give that delineates the kind of practice you do. So the present scenario, and I'm going to look at it, I want all of you to look at this particular map. And the reason I took this particular place is because there are some places where too little is done and is done too late. If you take Bihar, in the public sector, only 2.6% of women have cesareans. Lack of hospitals, lack of whatever. Can we have the lights down, please? It's for whatever reason, this will result in maternal death. There is no question about it. If you have too few cesareans, you're going to have maternal death. You look at their private sector, and that is almost 30%. 1 out of 3 women are having that. And then we have places like Andhra and Tamil Nadu and your neighbors, Telangana. Okay, now in the private and your private sector, in Andhra Pradesh, it's 25.5%. 57%. In the public sector, it's 1 out of 4. That's a large amount, okay? Right. But if you look at Telangana, in the private sector, almost 80% are having cesarean sections, okay? So we have to, I mean, somebody has to, before the government comes and clamps down on us, we as a professional body have to look at this fact that we are doing too much and we're doing too soon for very few indications. So, are cesareans really bad? Is it really a problem? Can we turn this down? It's very distracting to have, because I know you can't see the slides very well. Can you just cut this off, please? Are cesareans really bad? No. But if you look at what WHO said, the cesarean section rates higher than 15% are not associated with reductions in maternal and newborn mortality rates. If you're saying, I'm doing this to save the mother, I'm doing this to save my precious babies, my babies are all precious, my mothers are all precious, and I'm going to do cesarean for all of them to save them, the WHO clearly says that a rate beyond 15% isn't going to make a difference. But this ship has sailed. I am going to be very surprised if any unit has a cesarean section rate of 15% or less, right? But what is actually happening? This rate of cesareans, particularly in public institutions and in private institutions, it's straining economic resources. It's straining the resources of the whole country. It's straining the resources of the patient, okay? And we know there is enough evidence to show that cesarean sections increase the risk of spontaneous abortion, abruption in the next pregnancy, placenta previa, and you know that there has been an epidemic of placenta accreta. Women are dying of placenta accreta only because they have had a cesarean earlier. Uterine rupture, okay? And very, very important, babies are now having a problem with their immunity. There are more risks of having asthma, of allergies, of inability to deal with infections. The babies who are born by cesarean have a completely different biome. The fact that the baby is born through the vagina seeds the baby with a lot of bacteria, which protects it in its later life. Now, there's some crazy stuff which has come out. Now they started doing vaginal seeding. They take a swab from the vagina and put it all over the baby's lips and eyes. It's not a joke. There are papers and papers and papers on this, but very clearly, it's not to be done. Don't get carried away if you read about it somewhere. Do not do it. It's complete. It's been shown to cause problems for the baby. Now, this is where we're all going to struggle, okay? Subarna Ghosh, who wanted to have a vaginal delivery, felt that she had lost all autonomy. She had to have a cesarean, and she brought out this huge change on change.org. She brought out this petition, make it mandatory for all hospitals to declare number of cesarean deliveries. Please tell everybody. She's begging, and the number of women who have signed up this petition is enormous. And immediately after that, Maneka Gandhi went on this name and shame thing. And every doctor was so angry. They said, you know, how can they name and shame us just because we are doing cesarean sections? The question is, do we deserve this? Do we deserve to be named and shamed for doing cesareans, which we think are saving our mothers and saving our babies? Because we know a cesarean is life-saving in many, many situations. It could be for the mother, it could be for the baby. But the problem is that cesarean has now become medicalization of a natural process. To go back to that birth canal thing, you know, the reason that was put in there as we developed over millennia, as we developed as a mammal, if it was the wrong thing to do, somewhere along the line, we would have ended up with a zip on our bellies. If the cesarean section was the way we were supposed to have babies, right? So we continue to have the birth canal, and that's why cesarean section definitely is medicalization of a natural process. The problem is, patients are getting angrier and angrier. You know, told at 20 weeks you need a cesarean. At 20 weeks, how do you know she needs a cesarean? And then you have a fibroid. You have to have a cesarean. And how big is the fibroid? 22 millimeters. Huge number, right? So you have a fibroid, you have to have a cesarean section. You're a diabetic, automatic cesarean. We hardly see macrosomic babies in our GDMs in this country. Okay, in fact, we have smaller babies. But you have a diabetic, you have diabetes. All Western women have macrosomic babies if they have GDM. So you're going to have a cesarean, okay? So people are getting angry. There's a loss of trust. People don't trust obstetricians anymore. So look at this, Hospitals should not make a business of doing cesarean and cut the body of mothers and lure of money. This is all from online comments, okay? This is not something I made up. Unethical doctors are not fit to be doctors. They should stop their unethical hospital and clinical business. They're also a threat to humanity. It's becoming a money-making mode, compromising medical ethics. People are furious. Those doctors who carry out cesarean section surgery unnecessarily should be exposed and their license should be terminated. Such unethical doctors are not fit to be doctors. They should start a retail shop and do business. People are angry, okay? And we are seeing this anger in many things. When a cesarean happens, and something happens to the mother or the baby, hospitals are being broken up. So what is the problem that we have in a small setup? One, we have a small staff size. Both doctors and paramedical, we have a small staff size, right? Anesthetist, all of us don't have in-house anesthetists, okay? Because your practice is too small to have somebody sitting there 24/7. You have to call them. Managing emergencies becomes a problem because you have small staff. Access to blood bank. None of us have blood banks in small hospitals. You have to, at that point, in an emergency, start looking for blood. But so, what are the strategies we have to reduce cesarean section rates in small hospitals? Most importantly, start a group practice, okay? People say it's not possible. Okay, and you have to be older to attract doctors. I was 31 years old in 1983. Don't do the math. Do not calculate how old I am right now. In 1983, I was 31 and I started having registrars. Young doctors joined as registrars. They progressed to junior consultants. After they worked with me for 2 years as junior consultants, they were upgraded to senior consultants, which means that during their junior consultancy, when they were working with me, they were trained by me. They followed protocols. They knew everything. They knew about external cephalic version. They knew about internal portalic version. They learned all this, and then they got independent practice. But all the patients belonged to E.V. Kalyani Medical Center. They did not belong to any individual doctor, okay? And they were seen in rotation by all of us, so they knew all of us. They did not feel that if they came in an emergency and one of us was not there, they didn't feel abandoned, okay? And strict protocols were followed by everyone. If the patient had shut her eyes, whoever she saw, she would get the same investigation, same things we said, okay? We did the same things. And that's very important. You have to be OCD, like I was. So you have to do that. And as I said, we had charts, and I don't know how clearly you can see. So we have high-risk pregnancies. These charts are kept with us. This is a 4-page cardboard chart. And you can see the kind of high-risk pregnancies we were dealing with. So anybody who has their chart in their hand knows what's happening right there. Everything is there. All the reports are entered. And this is so you can see there are 3 different handwritings because 3 of us have seen her in rotation. So each one is following. Everybody knows what's going on with them. Advantage of the group practice is around-the-clock labor room coverage, and emergencies can be handled as a group, right? So there's always somebody else to help you. You're not there in the middle of the night with a shoulder dystocia and nobody around you, okay? And the fact that a person was senior was always jumping in to help. So we all worked together. It was very, very important. And that's how we were able to keep our cesarean section rates low. Our cesarean section rate did not go above, in the 32 years that I practiced, my total cesarean section rate did not go above 22 to 25%, okay? In a practice which had 40% high risk pregnancies. But remember, does that mean my babies were dying? No. Our perinatal mortality rate never went beyond 10 per 1,000. Mostly it was around 8 per 1,000, which is equivalent to any Western country, okay? Right. Now, try to make it easier. When you have a smaller group, do elective or planned deliveries, okay? Because then you get a big bunch of low-risk pregnancies out of the way, and they are not going to come and take up your resources, your time resources, basically, right? So what you do is do membrane stripping, okay? In multiparas, membrane stripping, they will come back within 48 hours usually, and they will deliver. Elective and selective induction. You can't induce every woman, Okay, if she's completely uneffaced, you're not going to do it just like that. Okay, in low-risk mothers, you plan it. Okay, and effective ripening. You can't just say, I'm going to induce, give her half a, ripening thing. You don't just give it once. It's not work. I waited 2 hours, no pains. I'm going to do a cesarean section. Okay, you can't. You have to put your heart into it. Effective ripening. And this helps because you have a group. So if just because you're not there, it doesn't matter. Somebody's following her beyond you, right? So through the 24 hours, there is somebody covering you. And start inductions in the morning, okay? If you start it at 9 o'clock at night, all night you're going to be bothered because somebody's going to call you and say she's having pain, not having pain. I think there's a dip, there's no dip. So start it in the morning, let her sleep through the night, give your third dose because I'm still, I was never a misoprostol person. PGE2 gel. So we used to give 2 doses, let her sleep, next day morning give another one if necessary, and then go ahead with induction, with augmentation with oxytocin. We had a very low cesarean section rate in these women. Now this brings us, obviously, do inductions increase cesarean rates? Remember this particular meta-analysis and systematic review came out in the American Journal in 2015 because we've been following this and we've been believing in this for a very long time that inductions don't raise cesarean section rates, but this validates it. This is by Bergella and Saccone, I don't know. At full term, in uncomplicated singleton gestations, they are not associated with an increased cesarean rate, and there's overall similar outcomes compared to expected management. The key to this is good ripening. Wholehearted ripening of the cervix. Wholehearted induction. You can't put 2.5 units of oxytocin in 500 ml and say it's going to work. It's not going to work. You have to go with the 5 units in 500 ml, and it has to be done with a pump. It has to be monitored carefully. You don't get unnecessary problems with that. So it has to be done well. That's the most important thing. You have to rethink labor, okay? People are saying patients are demanding cesarean. I don't want to go through labor, so do a cesarean. Okay, I'll do a cesarean because you asked me for it. No, you have to counsel them, okay? Make delivery a pleasant experience. The one thing, the patient walked into our hospital, from the reception onwards, people were smiling, helping her, the ayas, the nurses, everybody made her feel that she could do it, make delivery a pleasant experience. It has to be comfortable. It has to be private. You can't have just anybody and everybody walking through and through with it. You have to be kind. You have to be empathetic. Women are nastier to women than anybody else. Just think about it. We are the ones having the babies, and I think Evita is going to address this very, very important issue. We are the ones, we've gone through labor. Most of us have gone through labor. We know it's atrocious. Why are we being so nasty to our women? So be kind and empathetic, and they will go back and tell everybody, you know, you go there, you have a wonderful delivery, others will come looking for vaginal birth. Have husbands in the labor room. From 1981, we've had husbands in the labor room. They're fantastic in the labor room. When a patient wants to kick you, bite you, scratch you, just put the husband in front.